Okay, Sue, if you'd like to start.
Hello and welcome everyone. Very warm welcome from me. I'm Sue Benson from the Journal of Dementia Care and Dementia Publishing, and very much looking forward to this webinar this afternoon, which should be a very interesting and perhaps controversial topic, which we hope will stimulate some discussion. So first of all, just to say that there will be a chance at the end to ask questions, either verbally or in the chat. And please if you have got a question, please do put it in the chat, but keep the chat for questions and maybe relevant comments, but not for general chat to each other. The webinar is being recorded and will be available afterwards on our YouTube channel. You will all get details of that. Everybody will be emailed about that. And the presentation will be available too. That will be sent to you all. So without further ado, I'd just like to welcome very warmly Paul Edwards to be our chair this afternoon. Paul is Director of Clinical Services at Dementia UK. So thank you, Paul.
Right, thanks, Sue. I'm hoping everybody can hear me. A very good afternoon to you all and welcome to this webinar, which I think is going to be fascinating. It's going to be, I know, well done, because I know the person who's presenting it, who has got a track record of being really brilliant at understanding and helping us to understand more about understanding behaviour and distress in people with dementia. Before I get onto that, just a few additional housekeeping things, of course. As Sue said, we're going to have a presentation from Ian for about 25 minutes, and then the opportunity for us to really get under the skin of some of the things that Ian talks to us about. And this is an opportunity for all of us to ask questions. Please obviously use the chat for that. Raise your hands. I will do my utmost to make sure that we try and answer as many questions as we can, and those questions are facilitated for you. And if I can try and theme things together if there's a number of questions all along the same line, so that we can answer them as a collective. I hope that works for you all. Now, these things are often done easier face to face, these kind of webinars. So we're all very modern now and doing these things virtually. So please don't let that hold you back from asking questions, though, because I this is such an important subject. We know it's important, and we know it can be quite a difficult subject for many professionals, many people living with dementia, and also many families who are providing care for people with dementia. So if you've got a question in your head, I would really encourage you to drop it into the chat, and we can see if as a collective we can try and answer some of those questions for you. That would be brilliant. And the more we do that in dementia care, the more we sort of interrogate things and ask questions, the better dementia care becomes, because we get all these different perspectives, we learn different things from different people, and we use our collective brains, if you like, to sort of try and find answers to some of these great challenges. As Sue says, I'm Director of Clinical Services at Dementia UK. I'm very proud to be Director of Clinical Services at Dementia UK. Most people on this webinar I know will know that Dementia UK is a charity that is dedicated to providing specialist nurses called Admiral nurses for people with dementia and their families. We have Admiral nurses up and down the UK, but we also employ Admiral nurses to run our clinics and our helpline services. And one of the key calls we get from families particularly, and sometimes professionals, is about how we help people with dementia in distress and how we understand and support different behaviours that come out from them. So it's a very pressing issue for facing people with dementia. So without further ado, I'm going to hand us over to the brilliant Ian James, who's working part-time with CNTW NHS Trust, done so much work on understanding behaviour and trying to put that into some kind of frameworks for us all to be able to much more easily in practice help and care and support for people with dementia and his families. So Ian, over to you and welcome.
Thank you. Thanks, Sue. Thanks, Paul. Right, let's share. The screen. Right. So can everybody see the screen?
Yes, Ian, I can.
Great. Okay then. Oh, well, thanks very much. So what I'm going to talk to you today is responding to distress. So I've been also writing the national guidelines for the British Psychological Society. And so I was just trying to get my head around how I was going to do today's talk. So what I'm going to do is I'm going to use something that we produce called Communication Interaction Training Program as a vehicle for what I'm going to talk about. I'm going to mention the term behaviours that challenge. So I'm not trying to upset anybody, but we've really struggled. We've done about 5 surveys across the UK about what is the best term to use in this area. And we do not have a term that everybody likes. In those surveys, the least controversial term is behaviours that challenge. I've got no doubt we will come up with a term with the next couple of years, which we will all adopt. But at the moment, we do not have a term. I'm very happy to chat about this later on, but this is the term I'll use today. Okay. So, yeah, why is this area important? I guess one of the reasons it's so important is that we've got some guidelines, the NICE 2018 guidelines, which talks about, in this particular area, that we should be using non-pharmacological interventions first. And then the guidelines they produce to help us do that, as opposed to medication, is abysmal. It's really, really poor. And this is really problematic because we do know with the big surveys, those done in the Cochrane surveys, there is a lack of evidence of non-drug interventions. So we can have colleagues turn around and say to us, I'm very happy to use non-drug interventions, but you haven't got a very good evidence base. So it's beholden on us to produce that evidence base and produce practical interventions that can be used in all the different settings we work in. And if you want to have a look at one of the papers that we discuss about the problems with NICE, if you can see that grey paper there. Okay, so we were, after the 2018, I was really upset with the guidelines. So we went away and said, okay, what do we need in our trust? What do we need to help us determine what we're going to do in the community, on the wards, in the care homes? So we decided to put together a compendium of evidence-based tools. And typically me, I went and so I am obviously, I've worked in dementia for 25 years or more, but I've always drawn from outside of the dementia area. I think our cousins in learning disabilities and other areas have done some fantastic work which we can adopt. So I actually went to the police. What do the police do? How do they de-escalate situations? What does the military do? So we produced I guess quite a Catholic tool in the sense that we borrowed from anywhere and everywhere and produced this magpie approach. The other thing I was very keen when we were producing an approach, it needed to be led by, certainly when working in the care homes, the care staff, they were experts by experience. When I would get called in every so often when there was someone was really upset and distressed. But in truth, the care staff had been dealing with behaviours that challenge for months and months and months, and are experts in dealing with the stress and distress. So what we needed to do is ask them what they were doing well and building on from that. And part of that, I guess, was looking at what they could articulate about their skill sets. And I guess it's not too surprising that staff know by doing. When you start asking, why are you doing this? This looks so good. Tell me about it. They really struggled. So part of developing a program was also helping the staff to articulate what they did. And because once you've got it, I guess, a template yourself, you can then start adapting it and sharing it with other people. So we've been using CAIT for a while now. We've been using it across numbers of different trusts. the important thing to say, it's not that different from some of the other really good material out there. You know, dementia care mapping, clear, voice, FIPS, all of these things are really, really good. They just stress different things. And I guess what I'm going to talk to you today about is some of the things that we've introduced, which may be slightly different from some of these other packages, but these other packages are still brilliant. So I guess we're just at our USP, really. Okay. So, sorry, my Liverpool accent can fail me here. Claire, Sir, over in Leeds Beckett, you talked about the importance of having case material in when you're doing training in this area. So within our package, we have Kareem, who we take from early stage dementia right through to late stage, where we're actually at the final stage. We are involved in working with him doing some restraint. And we'll talk more about this restraint issue later on. But this is really important to make sure that what we're doing is not just theoretical, but has a core in people, person-centered. Okay, so there are lots of things that support our particular package and lots of videos. So we have decided that we would have a multiphasic, multimedia support package around CAIT. So lots of videos. All these videos are free. If you go into Ian James Dementia, I think there are something like 15 package animations uploaded on that. There's lots of articles in support. Many of them are published in Journal Dementia Care. And we support most of our work through outcome data. And if you haven't come across this, this tool called CODE, Confidence in Dementia, by Ruth Elvish, I'd really recommend that. Okay, and here are some of the animations on some quite controversial topics. Our latest is the one on the use of therapeutic dolls. Is it a deceptive practice? Don't know. But we also have some other controversial topics there, the use of therapeutic lies. And you know, many people are unclear about whether we should use therapeutic lies or not, or about the term therapeutic lies. I've got to say that when somebody can no longer lay down memories and we're entering into their world, I don't know many people who can offer person-centered care without some form of untruth. And that might be worth picking up a wee bit later. Within our package, we have lots of games, and this is a very typical one where when we're working with the staff, trying to demonstrate the importance of, you know, when someone is struggling to find words, what can we do? How does that feel? So this is supposed to emulate that sort of thing. Here we have got people to describe a picture, one person seeing the picture, one person describing the picture, the person describing not able to use key words. And we look at how people get around not able to use these words, simulating the word finding. The thing here is obviously the people who are doing this task have, you know, I guess they don't have any deficits, so they can do that, but it just demonstrates how difficult these experiences are. We do need to know about the brain. Obviously we do. And this is really important part of any teaching package, is looking at what parts of the brain maybe someone has deficits in, and what's the function and what's likely to happen when they are having trouble with their frontal lobes, their occipital lobes. How will that change their sensory perception, their ability to navigate their world? One of the key things about, I guess, my work is I've gone into, over many, many years, care homes and on wards. And whenever you go in, they always talk about having a model of needs or an unmet needs. Now I've got to say, I've really struggled with this concept, because every time you go into a different care home, they've got a different conception of needs. And so how can we have a philosophy of needs and unmet needs if we're not talking the same language? So what we did a number of years ago, we produced a set of 8 needs. We did this with care staff in care homes. And we think these are universal needs. and we've done a lot of work on this area. So whenever we go into a care home and someone's distressed, we ask, are any of these needs not being met? Is there a sense that the person doesn't feel in control, doesn't feel safe? They don't have a sense of belonging here. They're not having fun, they're not occupied. So this is quite a good checklist, just looking at whether someone's distress may be a consequence of one of these needs being unmet. I do realize I'm going through this very quickly. The other thing that I think was important was that often when we were going into different settings, people would describe distress in terms of labels. They'd say, that's pulling someone's hair, that's being aggressive, that's, well, they wouldn't say walking with purpose or without purpose, they'd say wandering. So they had these key terms. And when you look at it more closely, obviously, all of these actions have a story behind them. And what we need to know to help deal with people's distress and why they're behaving in a kind of way is look at the story. Because before that particular distress happened or that behavior happened, there was a phase where they were not behaving like that. And we need a rich description of what that's like. What keeps this person in a state of well-being? And when when something is triggered, we're all triggered by different things because we have different needs. What are the typical things that trigger that person's distress? And what does this person do as their distress gets worse? What is their type of escalation? We should find out something about that. And when they get really, really distressed, do they get very, very upset, tearful, or sometimes do they hit out? And what do they do then? And how long does it take them to become calm again? Once we know someone's pattern, someone's story around their distress, we then can start looking at interventions which are bespoke and fit that particular person. And this is taken from our colleagues in learning disabilities, our PBS cycle here. And it's really important. So we're no longer saying it was hitting out. We're saying there's a story here. This is what happened. And these are the phases of it. For this particular person, the best thing to do to de-escalate the situation is X. And when the person is really, really stressed, this is what we need to do. So this is a really helpful way of breaking down distress. In terms of CAIT, what we were really particularly interested in our program was that because we knew staff were very good at de-escalating situations, well, what actually were they doing? If you observe staff, they've got fantastic communication skills, really, really good communication skills. So that got us thinking, what are these communication skills? And at the core of those communication skills are very generic communication skills. That's treating people with dignity, that's giving them control when we can, that's smiling, beaming, and that may be at times using banter. Again, which can be quite a controversial thing in different situations. So the core of their skills is this generic skill of good communication. Obviously, there are other skills there, which are dementia specific, knowing what happens when someone has deficits in their frontal lobe or has language difficulties or is being time shifted. What we also know is that most of the behaviors that challenge, most of the stress happens when we're in people's faces, when we're in their intimate space. So what we need to do when we're developing our skills and articulating our skills is developing programs that help us when we're assisting someone with bathing or getting up or shaving. And so part of our program is giving very practical skills and programmatic techniques for these sort of situations. And only then, after we've done all of those bits of training, do we think about the use of formulations and specific psychological treatments. And that essentially is the wheel of CAIT. Let me just take you through some of these. So our core communication skill, our core training is based on the idea of effective interpersonal interactions. So if we just look at this woman's face here, anyone's heart would be warmed by that smile. That's so important. But it's her knowing when to use it and when not to use it. And what are the consequences? Sometimes that could lead to disinhibition. So there are subtle skills here as well. Okay, so when we're developing this part of our package, we went outside the area of dementia care and we looked at other areas that were using skills, de-escalation skills, and the sorts of things they were using to improve their interactions. Now, one of the things we did, we went to the police, which I know sometimes might not be a great thing to say these days because they have been a wee bit of trouble. But let's see if we can look at this. So this is the work of George Thompson, and he went and helped the American police forces, the cops, to develop new skills. So one of the first things he wanted to do is get the policemen to look at what they were saying, the way they were saying it, and recognizing the way they said it had a great impact in the way they came across. So let's just look at this. I've lost my icon somewhere. There we go. So this is the George Thompson's work.
Hi, I'm Matt Fleischman, and this is your DTM Security Tip of the Week. And we're talking about verbal judo, the art of gentle persuasion. This was pioneered by Dr. George Thompson a number of years ago, and he has trained tens of thousands of police and contact professionals on the art of tactical communication, not pissing people off and still getting the job done. So gaining voluntary compliance is basically what it's about. And he had 7 things that you should never say to somebody, and provided replacement words or replacement sayings. And this is a DTM rendition of just that.
What's your problem?
Ma'am, I can see that you're upset. How can I help you?
Be more reasonable.
Okay, let me see if I understand what you're saying. So, you said you want to do X, Y, and Z.
Okay, so we took that concept into a care home and then developed our own verbal judo program. So this is the animation we produced to help teach this program. I'll just show you a wee bit of it.
Hello, this video introduces the concept of verbal judo applied to dementia care. This is a technique pioneered by Dr. George Thompson. He trained the American police force to resolve possible confrontational situations with simply a better choice of words. We carried out a survey with nursing staff and carers working within dementia to see how these techniques could be applied to their practice. We asked them to give us examples of phrases that they had heard being used that can at times cause a problematic response. These phrases may sometimes be used when staff are very busy or are under a lot of pressure. However, the wrong choice of words can make a situation worse. We're therefore going to show you 7 examples of these phrases and offer some more helpful alternatives.
Help! Please help me! I'll be back in 5 minutes.
Care staff reported hearing several phrases in response to this scenario, such as "I'll be back in 5, give me a minute," or "I'll come back later," especially when there may be more important things to attend to in that moment. These responses are also sometimes used when a person has been yelling for help all day for seemingly no reason. The problem with this phrase in particular is that people with dementia often don't have a concept of time, and giving a time scale such as 5 minutes may lead to further confusion or even despair. If you're not available to help immediately, an alternative might be,
Help! Help! Please help me! Hi Brian, I can see you need help. I'm busy right now, but I will find someone to help you.
Okay, it goes on and on and on. And what we're saying here is that these are not the ideal answers, but what we're starting to do is developing a dialogue about what could be said and the pros and benefits of saying different things. What we also want to do when we're, I guess, helping people to deal with distress is look at the areas where typically people can become from the trigger point to a high escalation point. And these are things around how to approach people. And using our magpie approach here, we've used some of the work of T for snow, too many Thompsons, T for snow. We've looked at how to talk to people, the use of nouns, the use of pauses, the use of stress at the end of key words, which are vital in terms of letting the person's brain catch up with what's being said, and also helping the person's brain to recognize what is the end of the sentence and the end of that flow of dialogue. So we do a lot of this kind of work. And also, what do we do when we have repetitive questions? How to deal with that? And what is a framework which can be used to deal with that? Because sometimes there's a lot of trial and error. But there's quite a lot of literature on the best way of dealing with emotional topics by substituting more functional emotional topics. And we call this the broken record technique. And also what you do when someone's time shifted. And as I said to you before, when someone can no longer lay down new memories, they're always going backward to get information to navigate what's happening in the here and now. That going backwards forces them back in time and into a different reality. And this is when we perhaps may need to use therapeutic lies or untruths. Okay, as I said to you before, in the final section, we deal with the more, I guess, technical stuff. And in a lot of our training, when we're helping people deal with distress, we may not need to go into section 4, because that has things like formulations and how to use formulations. And some staff and some family members don't need to do that, but we may need to use formulations in different units, and knowing the framework may be important. The importance of care plans are vital. These are our templates, certainly when people are highly distressed. And as you can see here, all we've done is we've taken that graph I showed you before and used that graph to develop a care plan. How to maintain people in well-being. What do we do when they start becoming upset, distressed, more agitated? And what do we do when they're very, very upset? One of the things I've noticed, I guess, over the last 2 years, many of the settings we go into, they say they do not deal with restraint. Well, that cannot be the case, because restraint involves you just putting any kind of pressure on someone's arm or hand or part of their body. And I find it impossible to believe that you can offer assistance for people with advanced dementia if you don't use some kind of pressure some of the time. But again, that's something that we may talk about. So in our training, we do a lot of work on the legal issues surrounding restraint and even PMVA, because we feel that this is important, that staff feel confident and competent to be able to deal with the infrequent times these happen. But once they happen, we need to make sure that the staff are safe and the person living with dementia is safe. And the best way of doing that is making sure they're well trained and well versed in these skill sets. As I say, we spend a lot of time with the legal issues surrounding this. Okay. So when we're delivering any kind of training, we don't expect the whole training packages to be delivered. What we expect is bite-sized training bespoke to different settings. So this is CAIT broken down into those bite size. So the Sussex East and West, their mental health trust, their acute trusts, their social services, and many of their care homes are getting trained in CAIT. And they're using, they wanted a common language to use across their region. And what they're doing when, say a social worker goes into a care home, a nurse goes into a care home, they will take bits of these different sections and just do those sections to get across the key concepts. Okay, so I think I've talked too long now, I think. So in terms of most courses, for training courses, I think it's important that train-the-trainer models. We know, again, from the work at Leeds Beckett, that unless you support training with lots and lots of supervision, it can be counterproductive. It can actually de-skill people, because people then recognize what they're doing is not quite right, but they don't have the skills, knowledge, or sometimes the support to do things differently. I think anything we do needs to be supported by practical papers, because when you try to understand or write the papers or even produce animations, you have to be very clear about what the function, the structure of what you're doing is. And these are some of the recent papers. The first two there are from the journal, published in the Journal of Dementia Care very recently. And as I say, there are about 25 articles on this topic, talking about some of the things I've talked about today. Okay, thanks very much.
Okay, I'm back. Thanks, Ian. That was excellent. Stuck to time as well. So, yeah, fascinating. Quick walk through some of that work about understanding distress and those different phases of distress and de-escalation. We bumped on a few topics like therapeutic lies and restraint, and I'm sure that people in this webinar may have some questions about that. So I am going to open the floor for questions. You can either put your hand up or ask a question in the chat box. Now there is a question for me there, Ian, which I'm going to take first, because I think Wendy asked a question very early on just about Abral nurses in Suffolk. We don't have any Abral nurses in some parts of Suffolk at the moment. We continue to work with commissioners to get more Abral nurses on the ground. It's a constant challenge that we have at Dementia UK. You know, we have teams around the country trying to get more and more nurses commissioned, and Suffolk is one of our targets for growth. Wendy, if you need to know any more, just email me at Dementia UK, paul.edwards@dementiauk.org, and I can, you know, give you a more reasonable update on Suffolk. Okay, hope that's okay. So really interesting from Ruth to hear about CAIT. Can this be accessed online? Ruth was asking Ian.
Yeah, so my advice would be, because if you want the whole package, there is a cost to it, but there's an awful lot of material out there that that is completely free. So all the animations are free. There's a few that are not, but most of the animations are free. There's tons of literature out there. The workbooks are free, so most of it's free. The idea was just to get if you want a formal training and a certificate and all that sort of stuff, there is a cost attached to it for the trust. But before you do any of that, I would look at what's freely available, and that may meet your needs.
Super, thanks, Ian. Di has put in a really good reflection and question in there. I don't know if you can see it yourself, Ian, but says, I'm confused about why the RAM framework aims to reduce the emotion rather than validate emotion. Calming someone when they need to express their emotions can be invalidating and defers issues. When people are validated, there are no need for therapeutic lies. It's a really good
which bit do you want me to say? So I didn't talk about RAM. So RAM is a technique that RAM essentially is a needs-based. RAM stands for is reduce the emotion, assess the need, meet the need. Okay, so this really came from work done in Sunderland. That what was happening when we looked at de-escalation happening in many techniques and why people got more distressed is that distress was met with distress. Distress in the carers was met with in a person with dementia was met with distress, and that was fueling the emotion. So RAM was an acronym just for people that when we're in a situation, it's often best to try to, and that might involve validation, and often does involve validation. But we need to think, either of us must be thinking non-emotionally, because emotional thinking is really problematic. So validation can be part of RAM. As a magpie,
yeah, we might have just lost you a bit there, Ian. Just lost connectivity a little bit. So you were just saying something about the magpie approach. So
yeah, so the idea is that we can start talking about, validation may well be an aspect of reducing the emotion. It's a key aspect. So the therapeutic lies, I missed the therapeutic lie, I didn't see that connection. So if we validate it. But validation, if you look at some of Naomi Bale's stuff, some of her stuff is pretty close to deceptive. If you look at what she's saying and what she does, so this is the problem with therapeutic lies. People tend to term things they do as being economic with the truth. Someone said to me, I don't use therapeutic lies, I use fancy footwork. And then all I said to them is, well, what do you do? And it sounded very much like a therapeutic lie to me. So I think we need to be a little bit careful. We should use them as a last resort, but there is a place for them. And yeah.
Okay, thanks, Ian. I'm sure there'll be more comments. I'm going through these from top to bottom, so apologies if I haven't scrolled up enough. Karen was just saying that, Ian, you mentioned some surveys around terminology, specifically behaviours that challenge. Could you let Karen know and the rest of the group where we might find those?
Yeah, so one of the key people is someone called Wolfson, WOLVERSON. So she's done 2 big surveys. We did 1 survey. So the sorts of terms, so there are certain terms that most people agree are not particularly good. PBSD is not good. Challenging behaviour, no, I don't think there's many votes for challenging behaviour anymore. So there's other ones which are slightly new. Obviously, stress and distress is the Scottish term. We also have behavioural and emotional expressions of need, which is an interesting one. But obviously it's a mouthful. It's long. It has emotions in there and needs, so it's a really good thing. But because it can be shortened to bean, lots of people don't like it. And so we have behavioural expressions of need. It's really, really tricky. And the issue is that obviously we need to take account of both what people living with dementia and the carers and professional staff use. So there needs to be a lot of work done on this. But as I said, there are about 5 papers out at the moment discussing this topic. Great, thanks, Ian. A really nice question now, and it's more of a comment as well, which I could totally understand. So I'm a carer for my husband, and the whole not lying is so hard. I don't want to lie, but when he has hallucinations, sight loss, stroke, Lewy body dementia, I really struggle to interpret his world. So Ian, do you want to say something about that? And then I might also want to say something to Amanda about that as well. So, well, so the way we, I guess, look at it, we see it as a person-centered strategy used in the correct way. So I think there is a place for it. Obviously, it's very controversial, but I think it can be used as a very important tool in people living with dementia. So, Paul, do you want to? Yeah, I mean, I suppose, having cared for my mum with dementia and been through some really, really tricky ups and downs and really tricky dilemmas, both as a nurse and as somebody that thinks about person-centered care, I think whenever I've used therapeutic lies, it's come from a really good place. It's come from a heart and trying to ease something that is very difficult for the person with dementia. And I think carers live and work in planet reality, and whatever you can do in the moment to try and help and support that person, has got to be the right thing. And it's hard to do because, the use of therapeutic lies, like Ian said, needs to be really person-centered, but I don't think carers should really beat themselves up about it either, because when you're working with somebody that's so complicated and so complex and in these situations that's so difficult to work through, we shouldn't believe that we're somehow failing the people we love, because we're not, because we're all trying to do the right thing by people with dementia, and where it comes from is usually a deep sense of concern and compassion for the people that we love. So that's probably what I would add to that. If someone wants to read, so there's a PhD student is just about to publish her work, and I was one of her supervisors, Jane Murray. And so what she did is she went on to wards and looked at the type of communication that was used in the wards and focused on the use of therapeutic lies. And she's produced a really wonderful taxonomy of lies. Probably the best one. It's a new PhD, that's why. But it's really, really good. But it's quite controversial because she sees banter as a therapeutic lie. When I always see banter as part of the fabric of society, you know, you're looking great today, or, you know, all that sort of stuff. And she's classifying that as a therapeutic lie. So that takes us into even more interesting areas.
Ruth, yes, it was Wolverson. I think Ian James mentioned about the terminology. We've got Di saying, you mentioned that people with dementia don't lay down new memories. What about emotional memories? Don't these continue long into advanced dementia? Also, Cameron and Linekamp teach empathy to conflict resolution for people with dementia. So
the emotional memories, absolutely, that's really important. So yes, and that's why we've got to be so careful. You know, people will take that sense of distress with them, and I guess that's why it's important to map out that distress in the way we were talking about before. I guess it's the idea of what motivates people. I guess that's where I'm looking at. And if you look at the animations we produced, it's a really good one based on Kahneman's work, Fast and Slow Thinking. It's a really good one. So there we have people with procedural memories and such as emotional memories, which are driving them. But when every so often they take a step back and look at what am I doing next, that's the key thing that drives them for the next goal. That's a really good point. Yes, emotional memories are key and often one of the sources of the distress.
Yeah, thanks, Di. Debbie asks, how can we access CAIT?
So as I say, CAIT, there's lots of stuff out there already free of charge. If you go on my ResearchGate, there'll be quite a lot of that stuff. If you do want to buy it, it's CNTW. So that's the trust. But I think probably the easiest way, if you wanted to know more about it and I can send you some material. If you send an email to me, that's probably the easiest way. You might get stuck in the labyrinth of a trust if you go through CAIT, if you go through my trust.
Okay, thanks very much. So Rosie's got, I think you've got your hand up. I think so. Over to you. Hopefully we can unmute you and you can ask a question.
Hello. Thanks for that. It's really nice to hear about CAIT. I work for a specialist dementia team in West Wales, and our philosophy as a team is very heavily based on Newcastle model and the work that you and others have done. I was just wondering, I'm a speech and language therapist, and I've been thinking a lot about our role in dementia, and I think as a profession, I don't think we've done people with dementia a good service at all, really, and it's something that we're trying to change. And I was just wondering if you had, given that your work is all around communication, I wondered if you'd had any dealings with speech and language therapists and, what sort of input they've had and how you see, I suppose, your profession and ours working together on this.
Yeah, we meet, so absolutely. So part of our program is developed with speech and language therapists. You are essential. I think you could revolutionize the work. I think you really can. So I'll typical me, I'll get a concept and that's really interesting, not really understand it the way you do, and then I'll write about it or produce an animation on it, and you'll see some of those if you check. So I think it's really, really important. And some of the wonderful things about the work of Teepa Snow is that sort of very practical communication, and that's what we need. We need more guidance in those areas, because it is the communication that deals with 95% of behaviours that challenge. So I'd really encourage you to get involved in the area.
Yeah, I'm sitting here with a survey in front of me that I did of Welsh, of speech and language therapists working in Wales with people living with, and with adults actually, and trying to find out what their services are like to people with dementia. And it's, it's not great, but it is improving. And I think you know, I've actually got to go and present it to the Wales speech therapy managers on Wednesday, and trying to sort of make a case for a better service, because it sort of strikes me that every single person with dementia has some degree of communication difficulty, and, you know, a huge amount of helping them and reducing the distress is around, like you said, around the communication with that person and the skills of carers, you know, whether not paid or unpaid. So yeah, I'm getting more and more enthusiastic about our role, really, and what we can do.
So if you want to look at communication analysis in the area, if you go to the voice.
Yes, I've got links with them actually, and I'm hoping to do some research in that area. But yeah, I think it's, like you said, it's sort of a slightly different slant on the same thing, isn't it? Yeah, really interesting. Yeah.
So those of you people who are interested, that's at the University of Nottingham. It's a big project. So I think it's Voice 2 now. The first project was published. They're doing the second one. In fact, they've got a meeting tomorrow. I know.
Thanks, Rosie. Just to say, speech and language therapists, one of the most underused and talented professionals that we need in dementia care. I also know that the new chief exec of the College of Speech and Language Therapists is very passionate about dementia care. So if you
Hopefully.
email him as well, he is. You know, I think there's an untapped perspective that you would bring to that, and it would be so useful.
Yeah. Thank you.
Quick question, Ian, from Di around CAIT being available to family carers as opposed to professional carers in care homes. You know, what's the view on that?
Yeah, so what we've done is that we've had certainly over the COVID period, because we already developed CAIT over the COVID. So a lot of the people who are coming on to our wards, we were sort of testing out CAIT with many of the family members, how this was useful. So when someone's going back home, what were the useful things? And that actually led us to doing some work. We're doing some work now with the Church of England, because one of those happened, a couple of those people happened to be members of the Church of England, vicars and so forth. So yeah, so I think it's really important. I think there are aspects of CAIT, and there are certain techniques within it which are specifically designed for family carers. I guess the issue there is that some of the language may not be used, needs to be adapted, I think, such as time shifting. Some of these concepts that we're probably more familiar with, and the notion of unmet need, the family members would need help with some of that material.
Yeah, for sure.
But one of the most useful things that I guess it was voted most useful little protocol was the BANGS technique, Susan Macaulay's technique. If you haven't come across that, look at Susan Macaulay. Everybody who sees this loves this thing called the BANGS technique. And it's about de-escalating situations where someone, say, lost a purse and is looking for the purse, is accusing you of stealing the purse. Yeah.
Okay, jolly good. There's some really supportive conversation going on in the chat about hearing and sensory deprivation, and trying to support with different kind of advice and different areas of health going on in there. I'm just aware that we're coming up to the last sort of 10 minutes or so. There's a call for your email, Ian. You said for people to email you as opposed to trying to get through to you through the trust. So if you could put your email in the chat, or make sure that's available. The other question is, I suppose, are your slides available, and how could that happen? Because I think there's some really useful information on those slides.
Yeah, I'll give it to you. Sorry, I'm just writing my
Perfect.
Yeah, so it is available.
Okay, so any more questions in terms of what we've been thinking about, what we've been learning about in the last sort of 50 minutes or so? I think the thing that I was just reflecting on is this, particularly about the language. We were talking about do we call it challenging behavior? No, we don't really like that. Do we call it behavior that challenges? Well, yes. And it's almost like we feel like we're being really apologetic for trying to find the right phrase. I suppose for me, it's just, there's a difference between PC and being person-centered PC. You know, there's sometimes if we get into the language of political correctness as opposed to seeing the person and what's going to improve that that person for that situation at that time, then we risk just talking about what we call the language rather than actually finding out ways of how we can really deal with these complicated situations. And I see so many people at the moment getting themselves like tied up in knots about the phraseology rather than the substance and what we can do to help people. Would you say that was controversial or accurate or not? Ian, what do you think?
So I gave a talk a couple of years ago, and so we were talking about this, and I said my preferred term at this moment, for various reasons, was behaviours that challenge. And one person in the room didn't listen to the rest of the talk, the rest 30 minutes, just because they were just kept coming back about this term. I think you're absolutely right. You know, I think it is an important topic, but we haven't got something that's quite right just yet. So let's accept that we haven't got it right. But if you become overly consumed by it, there's lots of other things you miss, which are vital in providing good care. So yeah, I think that's very true.
Yeah. Okay. Thanks for that. I wasn't aiming to be too controversial. There's lots of help going on around Lewy body and rare dementia support, and some links. Also, obviously, at Dementia UK, if anybody needs access to our specialist nurses, we run specialist nursing clinics and also a helpline. Go onto the website, and if everybody, you know, people are struggling with support, we also have specialist consultant abnormal nursing services for Lewy body dementia. They can provide help and support there as well. So all of that, if people listening to this webinar are struggling for support around particular issues around Lewy body or anything else, then, you know, you can get hold of an abnormal nurse, contact an abnormal nurse, and they can ring you back or do a video consultation or whatever it is that, you know, if you haven't got an abnormal nurse in your area. So please do get in contact with us. We'd be really happy to help and support as much as we can. Any final questions? I'm just going to go to Sue and Journal of Dementia Care, just to see that I'm checking I've done the right thing, not missed anything, made sure I haven't missed any questions from anybody.
I don't think so. Like you say, it's been quite supportive in the chat.
It's been very good. Yes, thank you. The only thing I've spotted is about earwax removal at home. I don't know if anybody's got the answer to that specific problem that's stopping a hearing aid service, somebody having a hearing aid. Apart from that, it's been wonderful. No. Thank you all very much.
I don't just on that, because I'm a nurse, right? So things like bodily functions, earwax, that sort of stuff, you know, wearing glasses, hearing aids, are really, really important. But I'm certainly finding that some of the things that were okay, patchy, but they're pre-COVID. So some of that kind of in-home testing for sight and hearing, and some of the stuff that you go to the GPs for like earwax removal, and those things are sort of ebbed away post-COVID a little bit more. So it's getting even more difficult for family carers to get access to support people with dementia, to maintain their sensory aids that they use. Is that just a perception of mine, or is that actually what's going on? Because these things seem to be getting worse for people. Getting access to these different areas of sensory support seem to have not really come back since COVID. Is that an accurate point? You could put it in the chat. Anybody got any views on that? Yeah, and podiatry. Yeah, thanks, Aileen. Yeah, we're seeing a lot of, even though they were patchy before COVID, some of these really basic but crucial functions to support people with dementia and their families just seem to have sort of ebbed away a little bit. We need to do something to change that. Maybe that's an article for the Journal of Dementia Care. Maybe that's a call to action. So I don't know.
Yes, absolutely. Yes.
Yeah. Okay. So I think it's got a couple of minutes left. I think it's probably time to wrap the session up. Thank you ever so much, everybody, for your engagement. It's really great to see that. Obviously, the slides will be available. I think Ian's dropped his email in. I think you're going to get a few emails, Ian. I just want to say thanks ever so much for Ian's time today. I know he's really busy, and it was a really brilliant presentation, and I think stimulated a lot of thought and actually challenge and conversation. So thanks again, Ian, and it's brilliant to see you because I haven't seen you for quite a long time. So it's really lovely to see you as well. I want to say a big thanks to our team behind the webinar, which is the Journal of Dementia UK team, trying to get these things together to make sure that we cascade information and share information and really interrogate ideas and concepts in dementia care to make us all improve the lives of people with dementia and their families in our society. So, and thank you all for joining. I hope you had a lovely time. I think we're going to sign off here, and yeah, see you at the next one. Possibly.
Thank you.
Thanks a lot.
Big thank you from me too, and thank you all very much.
Okay, thanks very much. Thank you.